these things aren't corrected unless there's a problem. It's just about the positioning of the uterus. Now you have a woman, the vagina is at this kind of an angle, and then the uterus is typically like that. That's normal. And if the uterus is, instead of being like that, is like this, then that is a retroverted uterus. So normally it's like that. This is retroverted. Then you have an anteverted one, which is like that. And sometimes it's even like that. And that would be anteflexed. And usually these things are not a problem. And if they are, something can be done. But in general, they're not really a problem. Anybody watch The Big Bang Theory?
Yeah.
There's this episode where Amy Farrah Fowler, she's someone who was very smart but didn't have a lot of friends when she was younger. They're having a sleepover, and she's all excited about it. And she gets to come, and then they play Truth or Dare because they think, and they teach her, they say, oh, you ask something personal. And so, or they make someone tell something personal about themselves. And she says, ask me because I really want to tell you about my anteverted uterus. And they're like, that's not usually the kind of stuff that you talk about in Truth or Dare. But I thought it would be good for part of this lecture. Okay, so that's the uterine displacement aspect. The next thing is ovarian cysts. Now question? Question back there? Okay. The next thing I want to talk about is ovarian cysts. And we discussed already that ovaries normally have cysts on them. They're made of cysts. They create cysts. And so sometimes you have an abnormally large or persistent cyst on the uterus. That's why sometimes people get an ovarian cyst. And that can cause pain or swelling. And it is sometimes managed with OCPs or analgesics, or if that doesn't work, they might have surgery. Now, polycystic ovarian syndrome is something that we've talked about. So that's somebody who has a lot of cysts on their uterus, on their ovaries, and they have a syndrome of chronic anovulation. So anovulation, what do you think that means? They don't ovulate. So a lot of times they are fertility clients, fertility patients, right? They also have an androgen excess. And so they might have, more body hair, facial hair. And they also typically are obese, and they have hirsutism, which is the hair that we talked about. They have insulin resistance, and of course that makes them at increased risk for diabetes. They have infertility, irregular periods, and it's diagnosed with ultrasound. They look at their ovaries, and they look like a bunch of little bubbles, right? Instead of just chewed gum. I think ovaries kind of look like chewed gum, but if you were to chew gum and blow bubbles, a lot of bubbles, and then bunch it together and it looks like all bubbly, that's kind of what polycystic ovaries look like. And they can be, as I said, they can be treated with OCPs that suppresses the ovarian activity. It can resolve the cysts. If the person is trying to get pregnant, they might give them clomiphene to stimulate ovulation. And a lot of times they give these women metformin, and that actually helps regulate periods, believe it or not, and it helps with weight management and increased insulin sensitivity, which is probably what you were thinking, because we talked about metformin in that diabetes lecture, right? It all comes back. So that's the story of polycystic ovaries or polycystic ovarian syndrome. Any questions about that? I want to go to the dermoid cysts, and the other name for them is teratomas. And these cysts are a closed sac within within the ovary, and it can have skin or hair or teeth, and they're kind of ugly looking, you know, and that's why they're called teratomas. It kind of sounds like terrible. And they don't really know the cause of it, and the person can feel massive pressure in the lower abdomen or backache. If you guys could not talk during lecture, that would be better. Thank you so much, because it's distracting. I'm sorry. The treatment for that is they're going to take it out. So that would be a dermoidectomy, because ectomy is out of me. And even if there's no symptoms, they do tend to take these out because they can become malignant. Questions on any of that so far? I want to talk about STDs or STIs. And these are the most common infections or infectious diseases, in the U.S. They're spread through sexual activity. And as a nurse, see where it says nursing, non-judgmental education, straightforward language, risk factors and behaviors. This is all the stuff you're going to teach and do, is that stuff right there. And you're going to give presentations in trusted establishments and teach, don't assume, use condoms. So as we go to different STDs in this lecture, I'm going to keep referring back to that spot where it tells what the nurse should do. I didn't keep writing that after every one, but you need it for all of them, okay? Okay. So I want to go to the next box where we have inflammatory disorders from STDs. We start with vaginitis, and the signs of vaginitis are itching, irritation, burning, just as it says in your PowerPoint, discharge. And the causes can be bacterial, and when it's bacterial, they call it bacterial vaginosis, so they call it BV. That's what they call it. It's also called Gardnerella. And it doesn't really have pain or local discomfort, but it does have a gray to yellow discharge with like a fishy odor. And it is treated with metronidazole. And it's actually an overgrowth of normal flora. So it's not really actually an STD, and we don't treat the partner typically unless it just keeps coming back and coming back. We treat that with metronidazole.
Is that the flagell?
Yes. So the other thing that you see for the BV is clue cells. And these are kind of characteristic of what they see on the microscope, and they are epithelial cells that are all kind of irregular around the edge. And I have a picture to pass around of clue cells that are seen with that. Another vaginitis is Candida. And this is another overgrowth of normal flora, and so it looks like a white cottage cheese-like discharge. This one is treated with clotrimazole, which is gyne-lotrimin. And the third one I want to mention here is trichomonas. And this one has a thin, frothy yellow to yellow-green discharge. We also treat that with metronidazole. And we would treat both partners for a trick. And I want to say with regard to metronidazole a few things. I want to say that it does give a metallic taste in the mouth, and that it can have a disulfiram-like effect or antabuse-like effect. And what that means is that if someone is on it and they drink alcohol, they feel sick. So you want to tell them to not drink alcohol when they're on metronidazole. Questions about those? I want to go to the next one, with the next box, which is the cervicitis. And cervicitis is inflammation of the mucosa of the glands of the cervix. It is typically chlamydia or gonorrhea or both. And they can certainly coexist. They're both reportable, meaning they must be reported to the CDC. What's CDC stand for? That's right, Center for Disease Control. So the way it's diagnosed is for a female, they would put in a speculum, and then they would take a swab that's on a very long, skinny stick, whether it's wire or cardboard, and then a little swab at the end, kind of the size of a Q-tip and maybe a little smaller. They'll put it in the cervical os and they'll turn it, and then they'll take it out and they'll put that in a culture tube. For a male, it's more invasive, and it's a more painful process where it's a penile swab. So it's that same thing, but they put it in the os of the penis, and there's more complaints from the male when you do that than there is from the female when you do a cervical swab. For chlamydia, the best treatment is a single 1 gram dose of azithromycin. 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 For gonorrhea, we probably would give azithromycin with doxycycline. And you have to refer sex partners for both of these because they have to get evaluated and treated. For both, absolutely. Absolutely. Because if you have it, your sexual partner probably has it. Say again?
I'm sorry, for gonorrhea, the men are
Azithromycin and doxycycline.
Okay.
And with gonorrhea, you're going to recheck in 2 weeks. Now, we talked about that gonorrhea and chlamydia can lead to PID. We talked about that before. Remember? And I just want to say that sometimes the people have no symptoms. And sometimes they have a discharge. Sometimes they have pain on intercourse, but sometimes there's no symptoms. I want to say that when someone has an inflamed cervix, that it makes them more vulnerable to HIV. And I just want to say one more thing back at the top of the page when we talked about BV, and which is also Gardnerella, that change in the woman's flora also makes them more susceptible to other organisms like other STDs and HIV. Okay? So that adds the risk. Let's go down to the next box on chlamydia, which is the most common cause of endocervicitis. And on this black and white, if you print it in black and white, you can't really see the detail of that, but if you look on your computer at that slide, you'll see all the kind of gory details of what that really looks like with chlamydia. As we said, the symptoms could be dysuria, discharge. It could cause infertility. How can it cause infertility?
Scarring.
Yeah, from scarring, that's right. Also, it can affect the newborn it can cause conjunctivitis or pneumonia or even stillbirth. Syphilis is our next, gonorrhea is the next box. Gonorrhea's nickname is the clap. And it causes pain on urination, urethritis, so inflammation of the urethra, discharge. I've got the antibiotics listed there for you. Complications of PID, which we already talked about. You already told me about, so I'm sure you got that. And it can also affect the newborn in the ways listed there. The next box is PID, which we have talked about at length. And I didn't talk to you about cervical motion tenderness, which is on there for PID. And what that is when they are doing the vaginal exam, they put 2 fingers in the vagina and they kind of get the cervix between their 2 fingers and move it back and forth. And most people probably wouldn't feel it or wouldn't feel it very much. But if someone has PID, it really is very painful. And they call it cervical motion tenderness. And they kind of, it's thought that the stereotype of it is they jump up, stop, and they call that the chandelier sign, like they're jumping up and grabbing the chandelier as if there was a chandelier over the examination table, but it's a thing.
Is it like gently or
It's just move it. It's just move it. Yeah. And if you did it with somebody who doesn't have PID, they'd be like, they might not even know or be like, whatever, I can feel movement. And if you did it with someone with PID, it's a dramatic thing. So we want to, for diagnosing it, to get a definitive diagnosis, we can look at the endometrium in a biopsy. We could ultrasound and do a laparoscopy. See, it says medical ABX. What does ABX mean? Antibiotics. Yes, it means antibiotics. Broad spectrum antibiotics. If necessary, they'll do a surgery. If somebody comes in to the hospital with PID, they're probably going to be kept in a semi-sitting position to facilitate drainage to minimize the upward extension of the infection. Questions? I wrote on here all those symptoms, and I can also say they might be asymptomatic. My next box is syphilis. And syphilis is a sexually contacted disease. It can also be gotten congenitally. What does that mean? Can be born with it. If a pregnant woman has it, the baby can be born with it. Yeah.
If the baby is born with it, do they normally treat that as soon as the baby is born, or the baby?
Well, yeah. When the baby's born with it, whatever symptoms, they would treat it with antibiotics and whatever symptoms there was. Yeah. So.
Question.
Uh-huh.
So if you know that a woman has syphilis and is pregnant, about to deliver, do they put them on antibiotic IV?
Do they or they
During labor? Or before?
I'll say probably.
I thought I seen something in the book.
It's so rare now, syphilis, luckily. So syphilis is something that is, it comes in stages. And the primary syphilis is a chancre, CHANCRE. And these are hard, painless ulcers. And they're sores. And they're contagious from 3 to 12 weeks. And of course you're going to wear gloves when you're examining that person. Secondary syphilis comes about 2 to 8 weeks later. And this would be a rash on the trunk or extremities, palms, soles of feet. They would also have lymphadenopathy. They could have a fever, malaise, weight loss. Then there's a latent period with no signs or symptoms, and that latent period can last up to 20 years. And then after that, there's a tertiary stage, and really 20 to 40% don't even exhibit signs and symptoms of this. But in the tertiary stage, it's most commonly aortitis, and a lot of times, what's a AAA? It's an abdominal aortic aneurysm, and that's sometimes the aortitis that is associated with tertiary syphilis.
Abdominal what?
Aortic aneurysm. So it's in the part of the aorta that's in the abdominal area, and it's an aneurysm. And that's what the aortitis of the manifestations of syphilis is. It can also be neurosyphilis, which can look like dementia or psychosis or meningitis. In order to test for syphilis, they do a VDRL or an RPR. And it's treated with penicillin, and it's reportable, which I wrote here in your box. And you have to notify sexual contacts. And see where it says nursing, see STD slide above? That's the one I pointed out to you earlier about what you're going to do to teach someone who has an STD. It's that same list of things. Let's go to herpes. Herpes is, there's herpes type 1 and herpes type 2. And they used to think that herpes type 1 was like sores in the mouth and herpes type 2 was sores in the genitals. But then there was so much overlap that then now it's really impossible to tell which one it is. So what happens is it's sexually or asexually transmitted from wet surfaces. You can have self-transmission. What do you think that means? Self-transmission. Yeah, if you got it on one part of your body and you touch it with your hand, and then you take that part of your hand, you touch another part of your body, you can spread it within your own body. It starts out with, pain and then blisters and vesicles on the genitals, buttocks, thigh, cervix. There's no cure for herpes. But and it does go to, after they get the pain and then the blisters and vesicles, then they kind of ulcerate and coalesce, which means they come together, and then they encrust. And there is medication that is used to shorten or suppress the outbreak, and that is acyclovir, Zovirax, which is right there in your box for you, or valcyclovir or famciclovir. And you can see the last three letters of all of them are vir, so you think virus. It can go to meningitis because it does live in the nerves, and that can cause fever, headache, myalgia as well. The next box is that you would teach self-care, and there's a list there of what you can do. And the next box is prevention, and I want to just circle proper hand washing, especially after touching lesions. Tell your patients that. My next box is your nursing diagnoses. And then you can see where I have anxiety. And then the next box tells you about what you can do to relieve anxiety. It's all written down there for you. The last box on that page, I'm not sure if your pages are the same as mine, they are, is HPV, which is human papillomavirus, which is the most common STI, and it causes venereal warts, which we've talked about a little bit. Say it again? Am I missing something?
Something else was the most common STI, or did not get it right?
Well, what?
She believes you said something else.
I said that that chlamydia was the most common cause of cervicitis. And I said STDs were the most common infectious diseases. So I realized that there's overlaps, but each one's different.
At this stage, every overlap will just throw me off guard.
Say it again.
I was saying at this stage, every overlap will just throw me off guard.
Yeah. Well, when you are less tired earlier in a day, look and see each one's different. STDs are the most common infectious diseases. Chlamydia is the most common cervicitis. They're a little different. Just know they're all common.
That makes my life easy.
But I would still focus on those things. That's a hint. Okay, so it causes venereal warts, and they can be on the cervix, they can be on mouth, the anus, and they're painless. We use a pedophilic solution. There's a vaccine which is Gardasil.
Does that really work?
Yes.
Thank you. Yes.
It's because I heard. Never mind.
You have to get it before you have it.
Okay.
It's not a cure, it's a prevention.
So you have to get it when you're very young. I think they start at 12 years old.
They start the kids at 12, yeah.
But if you haven't gotten it at that age and
You shouldn't be able to get it after that.
Yes.
But if you've already got it, it's not a cure. It's a prevention.
Okay, so if you're 21, you can't get it, Gardasil.
Is that what they say?
You can get it up to 20. Up to 20 something.
25. But I heard that it's less likely to be as effective if you were to get it at the age of 12. I don't know why.
Than if you got it at 12.
Yes.
Because you're more likely to have already been exposed to it at 25, hoping it's a cure. At 12, you are less likely to have been exposed to it, which would allow it to be preventive. Does everyone know the difference between a prevention and a cure?
Yes.
Yeah. So it'll prevent, but it's not a cure. So if you already have it, then it's not. Then it's going to be less likely to be effective. Okay, and then I want you to use that same box with all the instructions about how you're non-judgmental and teach and that whole thing that I gave to you in the beginning of the STIs. The next box is the pictures of the warts. Here's my color ones. And you can see it when you look on the computer, because it doesn't really print that well in black and white, but I'll share with you because I think they're just lovely. If you've got teenage kids or patients, show them those pictures. And it will help them to protect themselves. Those books are, oh, you have the color. There they are. We have a penis, a vagina, with a bunch of warts. The next box is cultural, where I wanted to teach you about genital mutilation, female genital mutilation, which we already covered that box. And the next one is family violence, and that box is pretty self-explanatory. I want to say child abuse is you must report it, and domestic abuse mandatory reporting varies between states. And it is mandatory in New Jersey.
You said child abuse is a must?
You must report it. go till 9:30, right? So let's try and get through HIV quick.
What? No.
Well, yeah. Let's get it done, right? You want to study it on your own?
No.
Yes.
Really?
No, you should do voice don't try to do that.
Yep.
How about that?
How about you study it and you do a voice and share it with all of them? Yeah, it's funny. HIV. HIV is a critical public health issue in the United States. 36.7 million people in the United States are living with HIV, and and 20 million of them are receiving ART, and that is antiretroviral therapy. So everyone who has it isn't getting antiretroviral therapy, and that's significant. People living with AIDS are often given this acronym of PLWHA. And so if you see that, that's what it is. It's people living with HIV and AIDS. As nurses, you need to understand it so that you can be a resource to people. Is your hand up?
No.
So you can be a resource to your patients. Antiretroviral therapy began in the 1980s. There's great movies made about that time period. Have you guys seen any of those? There's the Dallas Buyers Club, and then there was one with Matt Bomer too, like something about Normal Heart. It's called The Normal Heart. That's it. They realized in 1996 that if you give a person with HIV more than one medication, it works a lot better to attack the virus from different parts of the reproductive process. So now it's mandatory that they use more than one medication when they go on medication. Because the medications are getting more effective and they're more convenient and tolerable, the survival rates have increased dramatically. And because of that, HIV and AIDS has evolved into a chronic disease. Let's just talk about the immune system a little bit. We have your T cells that are a subset of the white blood cells, and one type of them is the CD4 cells, and they help initiate the body's response to infection. Unfortunately, HIV attacks those cells and gets in and tricks those cells, takes over the machinery of cell reproduction in those cells. So while those cells are going all over the body trying to grab onto aliens and get rid of them, these aliens, the HIV virus, is getting in there and kind of taking advantage of them, traveling through the body and spreading through the body and growing in those cells. And that's a big problem of HIV. It can be transmitted between when there's breaks in the skin or mucosa. And so people who have that have an increased probability of getting HIV. The reason why it seemed like it wasn't a disease of gay men in the beginning was because gay men have anal sex, and so that makes breaks in the skin there, and it made them more vulnerable. And that's why they thought that it was about the fact that they were gay, but of course it wasn't. And it can also be transmitted from mother to child. It is not transmitted through casual contact, and it is in body fluids such as blood, so that when people share needles, they're at increased risk for getting HIV. It's in seminal fluid and vaginal secretions, so that increases people's risk when they're having intercourse. It's in amniotic fluid, and it's in breast milk. There are 2 HIV viruses, 1 and 2. Most of them are 1. Donated blood is checked for both. Ways to prevent HIV are, well, if you want to prevent it from being a sexually transmitted disease, there's always abstinence. That will prevent that. Also, the consistent, correct use of latex male condoms can help. Non-latex condoms do not protect against HIV. Non-latex condoms do not protect from HIV. Polyurethane female condoms do prevent exposure with regard to semen and vaginal fluids. Needle exchange programs are helpful. Some people might want to judge that and say, why should we help this population? And the answer is that they deserve protection like everybody. And if you're not going to protect that population from spreading HIV, that will spread to other segments of the community as well. We want education, of course, like to avoid breastfeeding when a mother has HIV. Oral and injectable contraceptives do not prevent STDs or HIV. Healthcare workers sometimes are at risk to get HIV, so what do we have? We have standard precautions, which you guys know what that is. Also, when we think somebody has been exposed, we have post-exposure prophylaxis, and that involves counseling and support and medication, and it might be a combination antiretrovirals, which we will talk a little bit more about. HIV is an intracellular parasite. Always look at these words that start with intra or inter, and make sure you know which one you're looking at, okay? Intracellular, within the cell. They get in the cell, they kind of hijack the machinery, the cell reproduction machinery, and they use that to propagate the virus. It's a retrovirus. That just means that it lays down on the DNA in a backward fashion to replicate. That's really all that means. It does target CD4 receptors. We talked about that. It mutates really quickly. 1% of its genetic material changes annually. And because of that, it has a lot of genetic diversity. And because it has so much genetic diversity is why it's so hard to make a vaccine against it, because it keeps changing. It's very smart. So the 3 stages of infection, you have a primary infection is from the beginning of when the person is infected until the development of antibodies. It's about 2 to 3 weeks. And these people have a CD4 count of like 500 to 1,500. That's normal. And unfortunately, the antibodies are produced to contain the HIV particles and assist in removal, but they trick the cells into spreading the virus instead. What happens after the initial infection is the virus and the CD4 cells come to a little bit of an equilibrium, if you will. The immune system says, okay, I think I got this. And the virus says, for now, this is as far as I can go. So we're at like a set point. And that set point can last for 8 to 10 years with few symptoms. I want to say when they're in their primary infection and they don't know they have it, they might have a flu-like symptoms, and they test negative, but they're highly infectious. So it's really dangerous time. Then they get to stage 2, and that can last a very long time. Their CD4s are 200 to 499. And then stage 3 is when they get a lot of symptoms, a lot of immune compromise, and they have AIDS. Do you know the difference between HIV and AIDS? Does everybody know the difference between those two things? HIV is the virus that causes it. AIDS is the syndrome that they get. When someone has AIDS, they are their CD4s are like less than 200. And a lot of times in stage 2, they don't really have much symptoms. So they have a flu-like syndrome, then not much symptoms, then AIDS. The testing, there is the ELISA test that is used to identify antibodies directed against HIV. There's the Western blot. And now there are home tests that you can buy and take it home and see if you have HIV. They take about 20 minutes. You can get them at Walgreens. There's viral load tests, and that is ways of looking at the amount of virus in the person's body, in their blood, really. And the more HIV there is, the higher the viral load, and the faster the CD4 count will fall. This box lists the type of tests that measure that. They'll use those tests to track the response to treatment of HIV by watching the viral load. The next box is comorbidities that often happen with AIDS, and you can basically see that it can cause almost anything. Pancreatitis, hepatitis, cardiometabolic abnormalities. There are organisms on the body that won't infect a person that has a normal immune system, but when the immune system is compromised, they'll take the opportunity to cause an infection. They're called opportunistic infections. PCP is pneumocystis pneumonia. CMV is cytomegalovirus. Have you ever heard of Kaposi's sarcoma or Kaposi's? It's a cancer that is often associated with people with AIDS, and it looks like a lot of bruises on the body. And so that's a very common clinical manifestation of people with AIDS. The next box shows you respiratory manifestations. I want to say that people who do not have HIV have a 5 to 10% lifetime risk of getting TB. I'll say it again. People who do not have HIV has a 5 to 10% lifetime risk of getting TB. People who do have HIV have a 10% risk every year, annually. So what that means is that their immune system is so compromised that they're a lot more vulnerable to tuberculosis. That's what I'm saying. They have a higher risk every year of getting tuberculosis as a person with a normal immune system has in their whole life. My next box is gastrointestinal manifestations. And I want to say that where I say profound weight loss, that means greater than 10% of body weight loss. I want to say candidiasis is the most common opportunistic infection in people with HIV. Candidiasis, the most common opportunistic infection. Almost everyone with AIDS has it. My next box is the cancer manifestations. Kaposi's, as I said, is the most common HIV-related malignancy. B-cell lymphoma is the second most common. My next box shows you all the neurologic manifestations. I think I'm going to leave that. When they have dementia, you can see on a CT that their ventricles are enlarged because their brain tissue goes away. You know what I mean? Depression is obviously something that's going to happen to people with HIV. With regard to treatment, the protocols change and specialists meet across the country annually, and they use the CD4 count as a gauge as to whether they're going to start antiretroviral therapy. They will put the person on at least 3 medications, and then they call it HAART, all capitals, and that's highly active antiretroviral therapy. It's based on viral load, CD4 count, and symptoms. And one other thing it's based on is what? Their willingness, the person's willingness to take it and continue taking it. Because if they take the therapy and then they stop, they're going to get more resistance to the therapy. My next box is a list of ART goals. That's pretty self-explanatory. They used to wait till somebody got to 350, now they might start lower. The decision to start is based on their willingness. My next boxes are the different types of HIV medications. They're listed, pretty self-explanatory. AZT was the first one. It's the most well-known one. If you look to the next box, you see the protease inhibitors at the bottom there. They're the ones that are really turned things around and made it so that we can actually more successfully combat this disease. Drug companies go down to combination therapy. It's another box. Drug companies, when they realized that people need to take more medications, they started making pills that had several in the pill so that the person can take less pills. They're listed there. There's a box that you see effectiveness and adherence, and that is related to provider relationships, substance abuse. You want the CD4 count to increase 50 to 150 per year, but even when it does increase, we don't say that they're in a less critical stage of HIV. Once they get to a stage 2 or 3, they're there. Even if they can improve their CD4 count, they still are in where they were. ART is toxic to the body because it's toxic to HIV, so there's a lot of complications, and that's why you have to have a big conversation with them about how difficult it can be to stay on the therapy, because when they go off of it, they can get sicker. So they have to really understand all these kind of bad side effects of the medication. And then the last nursing interventions and complementary therapies, they're really right out of the book. So you can read that right out of the book.